Thank you, Mr. Chairman. So I've been asked to talk about cardiovascular effects of low tidal volume and hypercapnia. So I'm actually going to concentrate on hypercapnia. In terms of conflict of interest, I don't have any conflict of interest relevant to this talk, but I do think hypercapnia gets a bad rap. I think we've heard a lot about the effects on the right ventricle and so forth of hypercapnia. And you know, it's hard being CO2 these days. You know, you're a greenhouse gas and you're basically blamed for global warming, and you know, it's a tough spot to be if you're a carbon dioxide molecule, I think. So the rationale for hypercapnia in the critically ill, well, of course that comes from the lung. Now we're talking about the interactions between the heart and lung, so I won't spend too long on this part, but you know, we've known for a long time that if you reduce the intensity of mechanical ventilation and accept the cost in terms of hypercapnia, that our patients are protected from ventilation-induced lung injury. And this is the original description from Keith Hickling. And as you can see, in this, the survivors had really quite high PCO2s, and so did some of the non-survivors. But you know, there was no great difference in CO2 between survivors and non-survivors. And in fact, he phrased it in the original paper that they had basically been disregarding the arterial PCO2. All they thought about was reducing the intensity of the ventilation. They just allowed hypercapnia to occur. We're all really familiar with this diagram. Got shown a little bit less at this conference than it does at most intensive care conferences. But this is the tidal volume study, the 12 versus 6 mils per kilo tidal volume study from the ARDS network in 2000, showing there was a clear benefit of lower tidal volume compared to the then traditional 12 mil per kilo. And Gordon Rubenfeld and Len Hudson and Eric Swenson did a meta-analysis of the PCO2 and pH of the patients in the study at the day of entry into the study. And what they saw was really quite interesting. What they saw was in the patients that had 12 mils per kilo tidal volume, you had a progressive reduction in eventual mortality, the more hypercapnic and the more acidotic that you were. And this is really quite dramatic. I mean, the adjusted odds ratios were 0.32, 0.14, 0.06, so really low. There was a profound profound association between hypercapnic acidosis and improved outcome in the high tidal volume group. This was absolutely not present in the low tidal volume group, but it's an interesting kind of association. I was really fortunate in my earlier training to work with Brian Kavanagh in Toronto, and at that time he was looking at hypercapnia, and he was asking the question as to whether or not it had direct effects. And we wrote this rather provocatively titled article in the Lancet, suggesting that high CO2 might actually be a good thing. And we looked at the literature and found data to support anti-inflammatory effects, data to support positive cardiovascular effects of hypercapnia. And we and other groups then went on to look at induced hypercapnic acidosis. Now, we did this by giving animals carbon dioxide. It's quite different from reducing mechanical ventilation intensity. But what we found in a series of models, and this is a work again from the Seattle group, was that hypercapnic acidosis protected the lung against injury. These are animals that were given high mechanical ventilation stretch under normal capnic conditions. These animals got the same level of stretch under hypercapnic conditions, and you can see there's much less injury in the hypercapnic animals. But what about the cardiovascular effects? Well, this is more complex, and when we looked at this, I just wanted to focus now on the cardiovascular effects in this diagram. What we saw was that we might see a benefit of hypercapnia on the cardiovascular system. We would see potentially increased oxygen supply, improved oxygen offloading at tissue level due to the Bohr effect, and reduced oxygen consumption because hypercapnic acidosis or CO2 is a metabolic end product, and it actually shuts down cellular respiration. We also found in the literature beneficial effects on cardiac output. We do know that hypercapnia is a pulmonary vasoconstrictor, but its physiologic role is actually to improve VQ matching. And so we looked at some of these, and this is work where we made lungs ischemic and then reperfused them. And this is pulmonary artery pressure. And what you see here is that the animals that are hypercapnic have a raised pulmonary artery pressure, which is what we know from the physiologic effect of carbon dioxide. And that's compared to the animals that were normocapnic. But as I've said, the physiologic role of hypercapnia on the pulmonary vasculature is to match ventilation with perfusion. And this has been shown in quite a number of experiments to be the case. And this is work, again, from the Denver group from Eric Swenson. And what they did was they gave animals hypercapnia versus normal capnia. And this is ventilation and the distribution of ventilation and perfusion. And this is blood flow. The line in pink here is the hypercapnic acidosis line. And what you see happening is this is in the more normal range of VQ distribution. So it actually shifts the VQ distribution into the more normal range of 0.1 to 10. And in the extremes, there is less of it. So there's actually improved VQ matching. And we actually have seen this in our animal work. This is, again, work in ischemia reperfusion, but this is before we injure the animals, where we give the animals 0% CO2 right up to 20% CO2 in the inspired gas. And you can see there's a stepwise increase in PO2. This is also the cardiovascular effects have been very nicely demonstrated by Jean-Louis Vincent's group in Brussels. And what they did was they looked at hypercapnia in a sheep septic model. And they also compared it to dobutamine and found the cardiovascular effects were quite similar to those you saw with dobutamine. So what you see here is arterial CO2. It's raised in the animals that are given carbon dioxide. The pH is lowered. And what you see is the cardiac index is increased to a similar extent to that which is seen with dobutamine. And the heart rate, again, is increased. And this is an indirect sympathomimetic effect, because actually the direct effect on the ventricle is to depress its function. And in addition to improving cardiac output, it also improves organ perfusion, which is what you'd expect if the output was improved. And this is brain oxygenation, and what you see is a linear effect between acidosis and hypercapnia and brain PO2. And this is well known and well described, and we know that hypercapnia is a potent cerebral vasodilator. But we also see it in other organs. This is actually data from Dan Sesser's group, and they looked at the perfusion of the small intestine. Now, hypoperfusion of the gastrointestinal tract is considered to be one of the drivers of organ failure and multiple organ failure. And what you find here is that animals that received hypercapnia had higher intestinal PO2 both in the small and the large bowel compared to normal capnia. And we know that not only does it improve supply of oxygen to the tissues, it actually also improves oxygen unloading. We've known this for a very long time. This is the Bohr effect. And what you find is that tissue PO2 here at 40 millimeters of mercury, if you have a high CO2, you get a lower hemoglobin saturation at the tissue, which is to say there's more oxygen unloading at the tissue compared to normal capnia or hypocapnia. And that's all very well in terms of the physiology, but what do we know clinically and from clinical studies? And there are some insights I think that are important. This is work from the pediatric cardiac surgical literature. It's a study done back in 1997. And what they did is they took infants undergoing correction of congenital heart defects and managed them either with pH stat or alpha stat management of the blood gases. And pH stat is basically where you temperature correct. And when you temperature correct, you have a lower apparent arterial PCO2. So you end up actually having to give it CO2 during bypass to maintain normal arterial CO2. So what you see here in these children, this is the pH, and this is the different stages during the surgery. You can see in the alpha stat group, there is a normal pH, whereas in the pH stat, there is a drop in pH as you give CO2. There's also an increase in arterial CO2, as you'd expect when you give CO2 during bypass. And what they found in these children was that the children who got the CO2 had an improved neurologic function post-surgery. They had better EEG function, and in one particular subgroup, the detransposition subgroup, they saw a better hemodynamic profile, and these children got out of the ICU and got off a ventilator faster. And there was a trend, it was a pretty small study, but there was a trend to reduce mortality. So, so this is quite a provocative study. One of the problems, I think, with the whole sort of just debate around hypercapnia is that we often misattribute things. And this is to my mind, a very interesting study in this respect. It's from James Russell and Keith Walley's group in Vancouver. And what they did is they took patients with severe lactic acidosis, and they gave them a bolus of bicarbonate. And what you see happen is after the bolus of bicarbonate, arterial pH goes up. Bicarbonate goes up, as you'd expect. Arterial PCO2 goes up, because of course that's how it's buffered. They also gave an equimolar dose of normal saline. No effect on pH, no effect on bicarbonate, no effect on arterial CO2. However, when they looked at the hemodynamics, the effect was identical. So a bump in the wedge pressure, suggesting increased filling, no real change in arterial pressure, and an increase in the cardiac output. So it's not the fact they corrected the acidosis that improved the hemodynamics, it was the sodium load. And that often happens. We often sort of misunderstand data, and usually it's not as catastrophic as it's going to be for this poor dog in the cartoon, but it is important that we understand and attribute things correctly. It's tutored versus neutered, just for... Okay, you got it. So but there are some important studies in ARDS. They're small physiologic clinical studies, but they are important in terms of insight into permissive hypercapnia. One of them is from, again, a Brussels group, and what they did is they took, I think it was 10 patients, and they subjected them to rapid hypoventilation. So they halved or dropped the tidal volume from 10 to 6 at constant PEEP. And they found significant hemodynamic effects. They found the cardiac output went up, which is what you'd expect with hypercapnia. They found an increase in shunt, and they found a modest decrease in arterial oxygenation. Now, when you look at this graphically, you can see this is arterial PO2, and this is at baseline. This is when they induce the hypercapnic acidosis, and this is when they're reconstituted. And you see there's an overall drop here in PO2, and this is QSQT, or the shunt versus total flow, and you see there's an increase in shunt during the hypercapnic acidosis phase. There's a few important things. This was rapidly induced hypercapnic acidosis. They dropped the tidal volume from 10.3 to 6.5 mils just immediately. There was no change in PEEP. In fact, PEEP was reduced in the hypercapnic acidosis group. It went from 13, total PEEP, to 12. As we'd expect, there was an increase in cardiac index because hypercapnia increases cardiac output, but there was no change, or actually a slight drop, in pulmonary vascular resistance with hypercapnia. So what was going on here? Well, as I said already, there was an increase in shunt from 33 to 47%, so significant increase. But the issue here is more complex than just being about hypercapnia. What they likely had was significant atelectasis as a result of the major drop without a concomitant increase in PEEP. And that the dramatic increase in shunt was actually slightly offset by the effect of hypercapnia on PO2. Another very important paper in this field is from Antoine Veillard-Baron's group, and they took patients and subjected them to 3 different strategies. The first was a tidal volume of 8 mils per kilo, a PEEP of 5, targeting a plateau pressure of 22. They then decreased the tidal volume from 8 to 6, increased the PEEP, and increased the respiratory rate. In the third group, they kept the PEEP the same, but left the respiratory rate at 15 and used a humidifier which reduced the dead space. So they basically had 2 groups with hypercapnia using 2 different strategies compared to their normal capnic group. And what they found was that they saw that P to F ratio was increased with both hypercapnic strategies. Again, a physiologic effect that we would expect. They also found that alveolar recruitment was increased in the hypercapnic group. So if you look at the PEEP, so they gave these patients 17.5 centimeters of water PEEP as a test. And what you found is you recruited about 215 mils of lung in the normal capnic phase. It went up to 520 in the hypercapnic phase. So they actually had de-recruited the lung during the strategy. And when they looked at the hemodynamics, what they saw was RV strain and an increase in shift of the septum. But what you had was rapid hypoventilation-induced hypercapnic acidosis, which is actually not what we do in clinical practice. And it did have significant hemodynamic effects with RV dilation, LV deformation, and they dropped the cardiac index in their study. Interestingly, they found that the drop in cardiac index was related to the amount of de-recruitment. And that's sort of a line in the article. And so this brings me to what I think is really the problem here, which is atelectasis. This is work, it's an experimental study from Brian Kavanagh. And what they looked at was they allowed animals, they ventilated animals with a zero PEEP strategy over a number of hours and allowed them to de-recruit. And what they looked at was they then did echocardiography to look at the heart, particularly to look at the right ventricle. And when they looked at this, they looked at the right ventricular impairment score. And what you see at 120 minutes of this sort of atelectasis prone ventilation, they had a massive increase in RV dysfunction, which when they recruited the animal was partially reversed. So it was clearly due to atelectasis, which was resolved in part by recruitment. These are sort of still echo shots from these animals. And you can see here, this is during the de-recruitment phase. What you see is a very large RV and a compressed left ventricle. The PCO2 did not change over the course of the experiment. When they recruited the animal, you see the RV dilation reduces and we have better filling of the left ventricle. And when they looked at this graphically, you see the increase in the pulmonary vascular resistance to systemic vascular resistance ratio in these animals was partially reversed when they recruited the animals. Another important study is where an induced hypercapnic acidosis in ARDS patients, induced over 2 hours. This was quite severe, 80 millimeters of mercury of PCO2. And they looked again at the hemodynamic responses. And they randomized patients to either tromethamine buffer or to not correct the pH. And what they found here was, as you'd expect, there was a dramatic increase in PCO2, both in the pH corrected and pH uncorrected patients. And there was a decrease in contractility with hypercapnic acidosis. This was attenuated to some degree in the patients that received TAM. When they looked at mean arterial pressure, the hypercapnic acidosis patients did get a decrease in mean arterial pressure, which was partially reversed by TAM. And the effects on pulmonary arterial pressure, again, were partially reversed. So where does that leave us? Well, we know that permissive hypercapnia saves lives in ARDS by allowing us to reduce the intensity of the ventilation. And there's some encouraging data in preclinical models to suggest that there may be a direct beneficial effect. Permissive hypercapnia does have profound cardiovascular effects. And these are complicated because the direct effects are overbalanced or counterbalanced by indirect effects, like the situation with cardiac output, where it's a direct depressant and yet the sympathetic drive increases the cardiac output. All forms of hypercapnia are clearly not the same. I've shown you some data with induced by CO2 administration and others where it was induced by hypoventilation, and they're really quite different. And the rapidity at which we induce the hypercapnia is important. And the clinical studies so far done in ARDS patients are complicated by the fact that there is significant atelectasis, and this is now known quite clearly to be a pathogenic function. And we do know in our patients who have permissive hypercapnia that this is actually quite well tolerated in practice. So we always need to be aware, I think, of the cost and benefit of any physiologic parameter, and there will be a cost to fixing hypercapnia. With that, Chairman, I'm finished. I'll take questions.